Requesting everybody to please take up their seats. Welcome Dr. Sangita Reddy, and now I'll request our chairman, Shri K. Padmanabh Bhaiya, to welcome Dr. Reddy with a flower bouquet. Please take your seats, and requesting everybody to put their mobile phones on silent mode, please. Shri K. Padmanabh Bhaiya, Chairman Court of Governors, ASCI. Dr. Sangita Reddy, celebrity health reformer, if I may say that. Dr. Nagabhushanam, President, Essential Medical Services. Vice President, Vice Chairman, ASCI. Distinguished guests, students, faculty colleagues, deans, members of administration, and members of the press. It gives me great pleasure to welcome all of you. Gareth, please. To this V. Chandramowli public lecture, which we conduct every year and which has been sponsored by Essential Medical Services. We are extremely glad that today's lecture is going to be delivered by Dr. Sangita Reddy. And shortly, I'll tell a little bit about her, even though she needs no introduction. But this is a lecture which is in memorial of Dr. V. Chandramowli. So it is my great pleasure to tell a little bit about the person. Dr. V. Chandramowli was born in 1937, gold medalist in MA in Economics and first-class postgraduate history and doctorate in social anthropology. He taught for 2 years in Madras and served the Indian Administrative Service for 33 years. Highlights of his administrative tenure at the state and at the center were 9 years in General and Revenue Administration, both at the Secretariat and in the field, 5 years in Tribal and Social Welfare, 4 years in Food and Civil Service, Civil Supplies, 6 years in Labor and Management, 5 years as Governor's Secretary at Hyderabad, 4 years of specialization in land seeking in the Command Area Development, Natural Relief, and Institute of Administration. In his life, he authored 9 books and chaired 12 companies. He was a British Council Fellow at Sussex University and led the Indian Plantation Labour's delegation to ILO in Geneva. We are thankful to Essential Medical Services for institutionalizing this lecture at ASCI. Ladies and gentlemen, a little bit about our chief guest, Dr. Sangita Reddy. She is member of the founding family of Apollo Hospitals, and she's passionately committed to transforming health ecosystems in the country through technological developments. She has been conferred an honorary doctorate by Macquarie University of Australia, and she is the honorary council of Brazil in Hyderabad. A graduate in science from Women's Christian College, Chennai, Dr. Reddy has pursued her post-graduation courses in hospital management from Rutgers University, Harvard University, and National University of Singapore. She is presently director of 16 companies dealing in healthcare, alternate energy, real estate, and software development. She has been conferred many awards. Just a few I'll read out. In 2022, she was conferred the prestigious Women in Excellence Healthcare Award by FICCI. In 2019, she was presented with the Best Female Healthcare Leader award by the prestigious, it's a prestigious award by the Indian Medical Association. She is currently chair of the G20 Empower, a very influential initiative in India aimed at driving empowerment and sustainable development on a global scale. G20 Empower plays a prominent role in addressing critical challenges such as gender inequality, economic disparities, and healthcare accessibility among the G20 member countries. We are very proud that she is leading this initiative as a proud member of this thing. She is also a member of the Technology Development Board, Department of Science and Technology, and an executive member of NASSCOM, and was on the board of Development Institute USA and Gavi.org. She was an elected member of the Steering Committee on Health for the 12th five-year plan from 2012 to 2017. If I start reading her accomplishments, it's going to run into several minutes, so I'll stop here and I'll request our chairman to give his opening remarks and then request her to make her formal speech.
Good evening, ladies and gentlemen. I welcome you to this evening's program. I have great pleasure in inviting Dr. Srimati Sangita Reddy and also the chairperson, Dr. Nagabhushanam of the Essential Medical Services. And about the person in whose name this endowment is there, the DG has spoken. I just want to mention one or two sentences about the Essential Medical Services. This organization was started in the 40s or 50s, I don't know when, by a gentleman called Dr. A.P. Rangarao. And he was in the government, but he was sent for training abroad, UK. So he worked with the National Health Service for about 5 years. And when he came back, he went to the Director of Medical Services. And the director then was thinking this chap has come for a posting in Hyderabad. But this man said, no, sir, I came because I want to be posted in a tribal area, the most remote tribal area. So please send me there. So he went into very forested areas, at that time, opened a clinic and managed that for a very long time. And it is he who started this Essential Medical Services, this one, on a small budget. He never believed in getting contributions from outsiders. That's why it did not grow. Only 10, 15 members who were associated with it, they were the ones who pooled their money. And he died a couple of years ago. And now Dr. Nagabhushanam is heading that in a small way. They still do a lot of telemedicine for a remote village in that particular district, based from the Ramdev Hospital here. And they also run a training course for paramedical people, and all with their limited funds, and all free of service. That's what they do. So I think that is the type of requirement we need, because the topic of today is health equity. That's what she wanted to talk, health equity, the moonshot, India's moonshot. So the health equity is where they help, and the subject is extremely important, the health equity, because the Niti Aayog has produced a report in October 21, not very old, just about 2 years ago. And do you know what it records? The subject of the report is the missing middle. The missing middle is, it says, at least 30% of India's total population, which comes to about 40 crore individuals, have no sort of protection at all, financial protection for healthcare. The lower fellows have, the below poverty, the white card people. Incidentally, there are more white cards in India in some of the states than the population itself. So that is a different story altogether. But then the upper echelons of the society, they do extremely well. But this missing middle, how do you provide affordable medical care? This is the most important topic. The second one is, ever since independence, we have been talking of affordable universal health care. Now, that has remained a dream till now. Now, how do you achieve this affordable health care, universal health care? And the latest target fixed is 2030. That's what, 7 years. Now, I wish Dr. Sangita Reddy would speak on both these issues, how to go about that. And she is eminently qualified to speak today, more than qualified, I would say, because she represents a very premier organization, the Apollo group of hospitals in this country, and which was started about 40 years ago with a hospital in Chennai. And then they have more than about 70 hospitals now spread all over the country. And they have so many verticals like clinics, daycare centers, diagnostics, pharmacies, Apollo 24/7. You can always talk to them. And then a telemedicine network, all that. And this is the first corporate hospital in the country. And it has driven and it has powered the private healthcare industry in this country. So she represents that. In her personal capacity, the invitation card says, what does it say? And there is only very short, this one says global health influencer. She is healthcare technocrat, social entrepreneur, and humanitarian, and joint managing director of the Apollo Hospital. So we couldn't have a better candidate to speak about it. And essentially, as a person, I don't like the corporate hospitals a lot. I have my problems with that. But I make an exception with Apollo. I mean, because of the numbers. I mean, I told you the entire gamut of healthcare is, if I'm sort of angry with Apollo, nobody would look at me, for healthcare. I can't go anywhere because it covers the entire organization. But there is another reason why I like Apollo, because they're concerned about quality healthcare. And what they had done is, the Apollo quality program was started in 2010. As early as that, it's about 13 years old. And then the Apollo standards of clinical care in 2012. And they have been meticulously following these protocols, plus so many other things. So many organizations have recognized them as quality healthcare providers. And it is the most wired hospital perhaps one of the best in the country, in the world. So it has been recognized as a digital health most wired survey 2022. The hospital has been recognized as such. So because of these things and their specialization in various areas of healthcare, I admire the hospital in spite of my I would tell you, you might be wondering why I don't like the corporate hospitals. I think the aim of the corporate hospital, which is earning profit for their shareholders, doesn't go with providing affordable healthcare. I'm talking of affordability. But it has a great role to play in the sense what happens is their procedures, their costs are much less, or 1/4 or 1/3 compared to the international costs. So in promoting medical tourism and attracting the people, getting the foreign exchange, I think they have been doing human service. So that's one. Plus, if a man can afford to pay, why not? He can have all the luxuries. Great. So, but how do you bring in the equity part? I hope you would mention a little on that, Now, just a diversion, I wanted to mention what are the recent trends in medical care. Because she's talking of moonshot and all that. One is, of course, AI, the medical devices. Everybody is wearing a medical device these days. They check the sugar, they check the heart rate, all the things, And then second is the robotic surgery. Third is telemedicine, in which they have done. The fourth one is personalized medication, So for each individual, depending on these things, I think in all these areas, they've been doing extremely well. I lived in Delhi for a long time. I used to interact with her father, Dr. Pratap Reddy. Whenever something new happened in the hospital, he would invite me. I would go there and participate. So on the research side, they have done extremely well, So that is it. So I don't want to really. Only thing is, we again put it in a square manner. How do organizations like Apollo help in in achieving the affordable universal health care? That's one. What role can you play in handling the missing middle? Now, I also wanted to mention in this case, there is a not-for-profit sector of hospitals in this country. They are very minuscule, small ones. But some of the big ones are the Vellore Medical College, the L.V. Prasad Eye Hospital, which is here, the Amrita Institute of Medical Sciences at Kochi, and then the Satya Sai Baba Trust, which is also running a great hospital here. And there is the Kasturba and Gandhi Medical College at Wardha, which is the ashram, who have 1,000 beds. I had visited that hospital many times. And things like that. Or even Basavatarakam Cancer Hospital. So what they do is they cross-subsidize and then take care of the missing middle. So what plans does Apollo have, or, already is having, is another point which she may like to touch. One more thing I'm told is, Apollo hospitals, I don't know whether they practice this, but the charges levied to various patients in the hospital for drugs given, for nursing care is different, for procedures done and all that. I believe it is linked to the price of the room. If the room is the highest tariff, the prices also are linked to that. Now, does it help in equity? I don't know really. So these are some of the questions. I raise this because we have a course of hospital management here. We have about 70 students. So some of them may like to know some of this, That's why I have posed this. But I'm saying I'm a great admirer of this hospital network, because I think they take care of many things, without this one. So without much ado, I would request Srimati Sangita Reddy to deliver her speech. Ma'am, you can speak from there. If you wish, you can come here. I'll give you.
Namaste and good evening. Shri Padmanabhaya, Mr. Nagabhushnam, your Bachi, other senior dignitaries here, and of course the most important, dear students, who are our future leaders of healthcare. Good evening, and let me say at the very beginning that I'm appreciative of the comments made by Shri Padmanabhaya, and I'm also appreciative of the opportunity to share some of the insights. I will begin actually by sharing more of a dream, and the dream is of health equity for the country, which is not really linked primarily to Apollo, but to an overall methodology of institution building and sector building, which I believe is critical and important. But I must begin with why I'm here, and that is, of course, in the short term, because of a deep respect for your institution and the multiple invitations. Of course, my respect for Sri Padmanabhaya, and I'm very happy that the link between EMS and Mr. Chandramowli, which I didn't really completely appreciate, but I'm happy that some of the stories I'll be telling later have a co-linkage to that, as well as the missing middle. But also why I'm here is a story that began more than 50 years ago, when Dr. Reddy, my father and our chairman, received a letter from his father telling him that, we received your letter appreciating the new research paper that you presented. We are appreciative of the role you're playing in your hospital in Mass General. However, let me also tell you that in India, only 2 or 3 people appreciate what you're doing. How would it be if you came back to India and did the same thing here? And I think that began the journey of his carrying back, of course, his wife, who was very ready to come, my mother, and 4 daughters who were too young to protest, leaving the lovely country of America at that time to come back. And he began a small hospital or a polyclinic. But even in those days, he tried to do what was not available. So he put the country's treadmill Today you have a treadmill in every street corner, but in 1970, he put the country's first treadmill in Chennai and continued to innovate. So whether it was the consul generals of the city or people who then started coming from out of town, or the fact that he innovated on a preventive health checkup, that people from Vijayawada, all those areas, and then from Delhi, and then the bankers, everybody would start coming to Chennai. But one day he lost a young man before he had enough time to raise money to his heart surgery in the US and to get his visa. And that day, Dr. Reddy said, looking at his young wife and the two young children left behind, he said, Indian doctors are curing and caring for people all over the world. Why don't we give them the infrastructure to do so in our own country? And that's when the Apollo journey began. The journey was not an easy one. In those days, financial institutions did not fund hospitals, and banks gave a maximum of 20 lakhs. His personal income did not allow him to put in more than 20 lakhs himself. And with 40 lakhs, he couldn't do a multi-speciality hospital the way he wanted. He took a Swiss bank loan. Today we hear of FDI or foreign direct investment. He did FDI in 1980 by raising modules of $5,000 from doctors, Indian doctors in America and the Middle East, saying, you guys are not coming back, at least, give me equity to put up my hospital. And then he made it our hospital, because those 450 doctors who gave him $5,000, $10,000 and $20,000 became the ones who also came back during their holidays, raised the standard of healthcare. Some of them returned permanently and helped create India's first super specialty hospital that happened to be a corporate hospital because there was no other form of funding. So the primary purpose of being corporate was to enable public to get advanced healthcare. And the reason for staying public was when you are accountable to shareholders, you create surplus, which is not only distributed as dividend, but also surplus which is reinvested for growth and to stay current. And that was the primary purpose of being a corporate structure. So having answered that question and begun, let me share this, the moonshot. I was lucky enough to be with the Honorable Prime Minister in South Africa when India landed on the moon. And the Chandrayaan journey has remained in my mind as an exciting moment, because we were also small children in America when Apollo landed on the moon. And I continued to feel that events like this are the triggers for populations to begin to think and dream big. And if we're thinking and dreaming big, let us dream in healthcare, because that's the sector we know. So I have been, over the years, continuously looking at what more we can do. Our group, especially my father, has worked on this. Our consultants, our doctors, our managers have committed themselves to this. But I think at no time ever in the history of the world have we ever had the guts to dare to say that every individual can access good healthcare. But I think today we can. With a combination of science, technology, a global world, telemedicine, genomics, computational capacity, artificial intelligence, science bringing artificial protein. And all these are relevant, every single one. 70% of the population live outside cities. We need access to the doctors who live in high-end care. 50% of the world's children are undernourished, or 51% of India's children are undernourished. And then the ratios move from Africa to the other. The missing middle is definitely critical, but also the extreme poor. While they're getting the carbohydrate, they are still undernourished because of the lack of protein and micronutrients. And the social determinants of health, like clean drinking water, sanitation, and nutrition, are by far the most important. We put up new CT scans and proton machines, etc. But if you asked us, what would you think is more important for the overall health of the country, we will definitely talk about primary health care. And so as I begin this presentation, where is your, just, you can help me by telling me where to point. This is the sensor. So, no. Okay. So will you change for me? I'll just put my hand up. Okay. I'll try. No, go back one. So coming back to the broad ideology that the new normal in healthcare ecosystems must be about advancing health equity. So we think of advanced healthcare. We did, the first multi-organ transplant in this country. We're actually the world's largest solid organ transplant program. When Dr. Reddy visited Mayo, they actually gave him a special bouquet of flowers for that signal of leadership, because transplants are among the most complex things to do. But health equity is really what we should collectively all be seeking. And I think this ability to leverage the digital technology and build ecosystems. And here I want to stress on this word ecosystem, because before, people thought that the responsibility of healthcare was with your GP or your doctor. And then when larger hospitals came, everybody said it's the hospital's responsibility. And some governments in some countries, and we're honored to have the presence of the British High Commission, but the government or the NHS was responsible for healthcare. In today's new normal, where non-communicable disease are more than 60% of the burden of disease globally, has come the realization and non-communicable disease are primarily resultant of lifestyle. So the responsibility of healthcare is no longer that of the government, the hospital, the GP alone. It is primarily that of the individual or the empowered individual who is given the knowledge to begin to stay healthy or to find his symptoms of ill health or her ill health early in the day. So that shift in thought process is one important aspect which is moved on. I want to move to the next very important slide of so why health equity is a global challenge. Clearly, it's a steep objective because primarily of the fact that life is unfair. If you take a train, and again, I'm getting inspired by UK here, but if you take a train from central London, for every stop of the train you make, life expectancy falls by 1 year or 2 years. Because the further you are out from the center of economic availability, the further you are from access to care, nutrition, or knowledge about good healthcare. And this is data. And similar is the case in any aspect of economic skewing, that the rich are living longer than those who are denied of the basic care. And of course, the people in between, the differentiation is primarily relationship to a doctor or knowledge of how to take care of your health. So the new shift is really not money so much as knowledge. And we're going to talk a lot more about that because we're sitting in ASCII, which is a temple of knowledge. So it's a steep objective. Our priority and actionables are quite clear in that we must set health equity as a goal. Have you ever heard any country, any person, any ecosystem saying that we will achieve health equity? That every single person must have access to good health care? Not too many hands going up because it's just beginning. But trust me, by the time in the next 5 years or next 10 years, everybody's going to be talking about health equity. Because we cannot deny healthcare. As much as, we cannot deny food or education or access to clean drinking water. Now the new normal is that we must strive for health equity. One of the important aspects in this pursuit of health equity is a new point, a new data point. And that data point is actually the lack of unbiased data about health. Because we don't really understand who is denied. We had an earlier conception that people in the villages lived a healthy life. And to some degree they do, because maybe they don't have as much mental stress. But the fact is that they have multiple other problems. But as we see the shift, and why it's important to track this data is, they had a lower longevity because of the higher preponderance of infectious disease. But as infectious disease go down and get cured by vaccines, and the preponderance of non-communicable disease like cancer, all kinds of renal related disorders, diabetes, where India has 85 million diabetics, and systemic chronic disorders like diabetes are the beginnings of multiple other disorders. When that non-communicable disease starts going up, then the healthy lifestyle has a higher role to play. And our ability to create a healthy lifestyle in most rural environments is not too difficult, and I'm going to share more about that. But we need the data to study this, because the new important mantra is going to be population health. It used to be about bed to patient ratio. It used to be about patient to doctor ratio, population to doctor ratio. But it's actually about population health, because there is a preponderance of a certain disorder in a certain area. And you all have heard of, whether it's iodine or chromium or lead or each one of these. When we look at the population and overlay that data, then immediately as administrators, your ability to handle that particular problem changes entirely. Or your ability to correlate unhealthy lifestyle patterns with higher preponderance, whether it is, we're doing a detailed screening in Manipur, and I'm going to tell you about the incidence of chewing tobacco and mouth cancer, which is an obvious one. But all these will come up, and the solutions will become clearly visible when we have unbiased, well-captured data. And, moving on, I think the important thing also is the internet divide. Because much as we all love, the important aspect of telemedicine, if you don't have access to the internet, then how do you do telemedicine? When we did our first telemedicine in the year 2000 in our village in Argonda, we put together 4 telephone wires. And Bill Clinton, actually switched on the button, and 2 days before he came, we got scared if that may not work. So we asked ISRO for a satellite. And we put a small satellite because, showcase, chief minister, all that stuff. But we went on with satellite for 4 years. And then steadily our internet connectivity has got better and better. But today, when we're trying to do countries in Africa, when we're trying to do remote villages, even in Indonesia, we do mental health for remote villages in Indonesia. And their internet connectivity is not so good either. So the internet availability and the digital availability is becoming one of the important data points in health equity. And the last one really is AI. Our ability to have AI, use AI, to be interpretive across all levels. And I'm going to share more this thing of what is clinical AI, what is operational AI, and how does it signify. But this is really a mental map that I want to leave you with. That if we look at these important and interesting new areas, typically we used to look at access to medicines, beds and infrastructure. I'm taking all this infrastructure as a given and superimposing a new accelerator to health equity, which are these 5 critical points. I want to share with you another aspect which is accelerating and kind of changing the health profile as we look at it. And these are 4 trends which are driving health equity. So number 1 is really that the disease profile is changing. And why would I say it's a positive trend? The reason I'm saying that one is, of course, it's a trend that there's more non-communicable disease, but NCDs can be controlled by information, by knowledge, by healthy lifestyle, by early prevention. Whereas infectious disease, you go out, you catch something, it's not within your control. And you need science and an ecosystem and government to give you a vaccine and prevention. But NCD is in the hand of the population to manage themselves. And that's why it could be turned into a positive trend towards health equity. The second important one is that the area of care is shifting. We used to think that, the only place is the high-end hospitals. But care is shifting from the hospital to the clinic. We can do so much more in a clinic. And Mr. Richard is sitting here. He's a director in one of our companies where we have 400 clinics, and he knows how much we're pushing health checkups and clinics and prevention. But care is shifting from the hospital to the clinic, from the clinic to the home, and from the home to a 24/7 ubiquitous access to care enabled by your mobile phone and connectivity. So 5G ambulances will give you care in the ambulance. Your phone will connect you to your doctor, who will escalate in a call center, who will have an AI model. Your nurse will take care of you. You need not even go to the hospital for most things, except when you need a major surgery. Many of these things you do. But this is a very important, the point of care is shift. The next one that I really want to talk about is the cost of care is reducing. And you may think this is counterintuitive because everywhere health inflation is higher than routine inflation. And yet, if you look at a routine cost of care, when we started, we used to do bypass surgery for about 85,000. Even today, we can do bypass surgery for about 1.2 lakhs. The inflation in bypass surgery is lower than the inflation. Even onions have gone much higher than, the inflation rate is more. This is because of a series of things, because of knowledge, because of training, because of the cost of machines. And now with India manufacturing in here and consumables getting manufactured here. And finally, the most important is don't look at the actual cost of bypass surgery, whether it's 2 lakhs or 3 lakhs or even cancer treatment. The cost of a bypass surgery is 20,000 rupees, which is the cost of your health insurance to buy it. Because the burden of disease of the very sick, who are only 5% of the population, is borne by the community in a well-insured population. So with the model and the manufacturing and the changing environment, the cost of care can actually come down. So I'm giving you something which was typically counterintuitive, but it is true. And finally, the last one is a ubiquitous AI. These 4 trends are going to help us accelerate. And I'll talk more about AI later. So we'll move to our next slide, which I think is important. And this one is really thinking about healthcare at a community level and the interventions required to create health for all. Local community interventions, whether it's the food you eat, whether it's the way you dispose your garbage, or your sanitation conditions, and therefore you prevent gastrointestinal disease because you've created that. Many of these. And typically people would say that, we spend so little on healthcare. We're only 2% of our GDP. Unless we spend 5% of our GDP for healthcare, how will we achieve healthcare? I used to say these things. And now, India spends $176 per person on healthcare. America spends $11,582 per person on healthcare. India's current life expectancy is 69 years. US's life expectancy is 77.8. It's not a very big difference for 10 times the amount of money spent. But then it gets even more interesting. India's cardiac deaths are 235 per 100,000, whereas US's cardiac deaths are 335 per 100,000. So it's the time for us to start thinking that we are going beyond a direct correlation of money spent and outcomes and begin to focus on population health, innovative interventions, and positive outcomes. And that's what the current environment is enabling all of you to think about. And that's why I'm daring you to take this moonshot of health equity for the world. So there are many other channels, whether it's the management of chronic disease, because if I handle diabetes right, I will prevent you from having a bypass surgery. If I manage your diabetes and keep your HbA1c at 5 and 6, we will make sure you don't lose your eyesight or have to amputate your leg. And if I find your cancer at stage 1, you will not only be able to be cured, but you will be cured for a small cost and much, much less suffering. So one of the important aspects of fighting NCDs is early intervention. Towards early intervention, and I have this next slide, please. I have this, a few data points of what's happening in the country, and these are primarily government related. Many of these, I had the honor of being on the Planning Commission, on Niti Aayog's Health Committee and Design Element. But we have finished 800 million screenings in this country. This is non-trivial. 83 million people have had breast cancer screening. 56 million people have had cervical cancer screening. And you have 400,000 ASHA workers. And I realize there's still a gap. Anyone who's sitting here and saying, I went to my village, things are still quite bad. Somebody else may be thinking, I went to Gandhi Hospital, I saw so many people who had stage 4 cancer. It is not exactly where we are right now, but it's the direction in which we're going. The acknowledgement 5 years ago or 10 years ago, you never had this number or this orientation on prevention and early detection and screening being a methodology to prevent non-communicable disease. And that's why I put this first slide in front of you. The second slide, while I gave a positive note there, I have a slightly somber note here on my next slide, and that is mental health. Many people will not realize that 14% of our adult population is suffering from mental health. And why this is extremely serious is that all of us are in denial. Most hospitals don't have mental health departments. Most communities ostracize going to a psychiatrist, and the burden of mental health is translating into a higher suicide rate for many, many communities and segments of the population. So again, I kind of put light on this one, because unless we handle this appropriately, and it can be handled, we will be solving one segment of the problem while a different segment of the problem continues to grow. And the digital solutions in this space are outstanding. They are chatbots, they are avatars, they are interpretations, there's privacy. There's so much that can happen in terms of innovation in mental health. And that's why I wanted to take a minute on this. And leave you with this one thought: the WHO estimates $1 trillion is the cost of mental health to the world. So it is very significant. Moving on to, I think, my last slide in this series is just a culmination, or maybe one more, is that a combination of universal health access. And by universal health access, I want to take a minute to tell you another story, which is the story of Apollo Health Association. And most of you would not have heard of it. But Apollo Health Association was started 37 years ago, inaugurated by Moshina Kidwai, who was then the health minister, with the primary purpose of bringing health insurance to this country. And this was done as a result because while we were doing outstanding high-end surgeries and work, we also realized that health was the second most major cause of indebtedness. And people were selling their land or pawning their wife's jewelry to pay for our hospital bills. And that did not feel very good. But we also knew that the income levels will not grow as fast as we need them to, and health insurance is the only way. So AHA was a not-profit society to build awareness and to create research about insurance. In the year 2000, we did the first insurance model in the country for our village for 700 people for 1 rupee a day. We used that data to create the Arogya Bhadrata model for the police of Andhra Pradesh. We used that model to build Yashashwini in Karnataka for 300,000 farmers, and then brought that model back to Andhra Pradesh to do Arogyashri. We ran the back end of Yashashwini for 9 years and the back end of Arogya Bhadrata for almost 15 years. So health insurance, and then finally we had the privilege of deposing in front of the parliament. I spoke before the insurance bill was passed to say this is such a great need. And India is one of the few countries in the world where health insurance is in the health category, in the general category, and in the life category. And this has allowed us to create a 51% penetration of the country with health insurance. 200 million, 220 million people are covered by PMJY. Another approximately 100 million people are covered through the different state schemes who don't go into PMJY. And the rest is another 200 million covered by the private insurance. So approximately 500 million people are covered by health insurance, which is a significant achievement. Because now they worry about healthcare, not so much about the bill. And this is the way it should be. But besides that, in the same breath, I think when Prime Minister Modi spoke about PMJY, he also spoke about primary healthcare clinics and making them health and wellness centers. So there, 200,000 clinics and 75, the third piece is the health records. So if you see this slide, I'm talking about universal health through insurance, digital health through the National Digital Health Mission, and primary healthcare. These three pillars are the foundational pillars towards health equity and universal health access. But then it gets more exciting. And this new excitement is about enabling or accelerating the moonshot, because we have immunomics, and immunomics will help us cure cancer. We have proton therapy, which will give us cancer treatment with precision. We have robotics, which will enable a young surgeon to operate at the expertise level of someone who's practiced for 20 years, because the robot is doing some level of the precision management. And it goes on, CRISPR technology, genomics, proteomics, CAR-T cell therapy, all kinds of other stuff in conjunction with the human resources that we can train and the infrastructure that we can build. So please dream of this moonshot. And in addition to that, we have AI, we have the Internet of Medical Things, and I'm going to talk more about devices and what they can do. We have the cloud, and we have remote care. So this combination is leading us to really say that India can be on par with the best in the world. We have done it in high-end care. Can I have the video, please? We have done this in high-end care, and I have just a 1-minute video for you. This was done on our 40th anniversary. So the first robotic surgery on a collapsed vertebra. Asia's first en bloc combined heart and liver transplant. India's first female recipient of proton therapy. Robotic pediatric cardiac surgery. Conjoined twins being handled. The first dual implant of a mitral clip and a TAVR surgery. You've heard of TAVR, you've heard of mitral clip, you can do it together. And the last one, which moved very fast, was India's first liver transplant, which happened 23 years ago to a 4-year-old boy called Sanjay, who is today a resident doctor at Apollo Hospitals, Bangalore. So the story goes on, and while I may have shared with you some of the possibilities, I'm going to quickly tell you that this is not theoretical possibilities. Let me show you things we've done. Next slide. So 200 million patients, 150 centers, 200,000 cardiac surgeries with success rate on par with the best in the world. 25 million health checkups over the last 40 years on prevention, many, many areas, and then the Joint Commission accreditation, many milestones that really the credit goes to the 100,000 Apollo family members whose heart beats every day for giving advanced care to people. But then I want to move to some more innovation and one side of Apollo that you may not know. You think of us for heart surgery, you think of us for cancer, you think of us as 1066 an emergency. But did you know that we handle over 195 primary healthcare centers for the government and over 130 digital dispensaries? We used to do almost 500 earlier. And these are the first time we innovated 9 years ago and created a phygital dispensary for the government. We re-engineered their process. We upgraded the lab. We built a nice waiting room and a clean toilet. And we trained their staff and put in an electronic medical record. so that the doctor was practicing on care protocols that we had innovated within the Apollo ecosystem. And those rural people, when we took over, our average footfalls into a PHC was 6 per day. Within 1.5 years, the average footfall was 35 per day. So this is the kind of public know how to respond when you give good care. And so we've tried to build these models. We don't run them at scale. We do it under a quasi CSR Section 25 company so that the model can show. But moving on, we do tele-emergency in many, many areas, whether it's in the on Outer Ring Road, you may see some of our tele-emergency centers and our ambulance, but we do it in multiple areas, including, next slide, where we're doing it for small nursing homes. We're connecting into different countries, but we're handling the ICU beds of nursing homes outside of Apollo. Almost 200 beds are connected into one of our centers here. So this is an ability to connect the devices, the technology, the monitors, and the AI models and do a central monitoring station. Please believe me, this is going to happen everywhere. We now have 100 beds in Apollo hospitals outside of the ICU, which we call the connected rooms. Post ICU, you go into the room, you put on the patch, the nurse is watching everything, and then the other central monitor and our AI, which has early warning symptoms protocol, is also watching. So these days, we don't wait for a code blue. Before, I used to be very proud of our code blue protocol. Today, if you've announced a code blue, that means you never picked up the early warning symptom early enough. So the whole dimension of how we think of care is changing because of the technology which is available. And one of my favorite pictures in this one is when we do it in the Himalayas. So here we have up there in inaccessible areas where we're doing screening programs for the Javans. This is one of the army areas. And then the next one is a story of Himachal, where here a 27-year-old had a placental abruption while she gave birth to a child. 2 months of the year, this little town called Khaza is inaccessible by car. We treated the mother and the child by telemedicine. She had postpartum hemorrhage. We monitored the baby using the devices and training the nurse who was there because we had preset that emergency room. We had already trained the technicians, and then we were using this. We were monitoring the blood sugar of that child to make sure that this premature baby we did not lose. And finally, after 48 hours, they were airlifted into a larger center. And God's grace, we were, when they moved to Manali, those doctors said, a few years ago, we would not have saved this baby or this mother. We would have lost them both. So this is the way to bring down our maternal and infant mortality. By giving, we may not be able to move these high-end doctors or have a PICU, NICU in those areas, but you can put the technology and monitor them remotely to deliver almost the same level of care. This is one of the future which we're trying to showcase. Moving on is the mobile vans. So large number of mobile vans moving into OPD areas, treating multiple patients. Next slide is our cancer care screening. We're here. This is a project done in conjunction with the World Economic Forum, where we're screening for 5 types of cancer. We have the software, we have the early warning symptoms, and a low cost funding that they could not believe. Find Foundation is a global public good foundation, and they said, how can you do it for this price? So we said, come and visit us and we'll show you. Because let me tell you, one of the saddest things is not seeing, 80, 90-year-old pass away. One of the saddest things is seeing a 45-year-old in stage 4 cancer. Because you will be thinking, where were they when they had stage 1? Why couldn't I find them? So we must spend time, effort, energy, money on early detection, prevention, and screening. So that's what this is about. I'm also happy that we do a lot of work in teleophthalmology. Almost 2 million people screened. We give spectacles within 48 hours. This is one of the programs that many chief ministers love. It gives them lots of goodwill. We work with the governments in conjunction with this. Also, we work with other private bodies as their CSR partner, and this one was in partnership with the University of Pittsburgh, where we worked on diabetes early monitoring and prevention and control, not prevention. So many of these interventions are really an ability to think through. But where all this thought has come together and where we have a single showcase for innovation is really in our village. This village is the village where Dr. Reddy was born in Aragonda. Next slide, please. So total health, about 62,000 people have been screened from birth through life. We take care of their health. And here we looked at the social determinants of health. We look at a single disease. We track the diabetics. So the mobile van, there's a maternal health centers. Each one of these conditions are managed. So this is just one slide about the 4-year outcomes of the management of diabetic patients in that district. And then I want to take you on backward once to the artificial intelligence slide. So I had promised I'll tell you more about what we're doing in AI. I believe this is transformational, and any time you can spend on AI, please do. We have divided AI into, these 5 broad areas. One is really, what can you do for adoption? The second is how can you build data consortiums and look at regulation? The third is the actual computation and performance of AI. The fourth is what is the disruptive innovation that you're getting because of AI, whether it's early warning symptoms in ICU, whether it's cardiac risk prediction scoring, so that in a population health model, you can focus on the 15 people at risk, not all 100, because you don't have the time and the money to spend on 100 people. So this ability to do disruptive innovation in population health, and finally some breakthrough sciences, which have helped us really put this together. And I also call your attention to a report that we did called the EASE framework, because as AI is sweeping the country, the ethics around AI is very critical. And so the ethics framework is really for us in a article which has been widely published called the EASE framework. With this, I'm going to end with a small video on Aragonda. Maternal mortality in Aragonda is lower than any other subpopulation across 5 states that we studied. So if you see the trees which are planted, all these were community level. So we do in some areas 1 papaya tree, 1 drumstick tree alternately and tell them to share. We do women's programs extensively, not just about health, but also community work. And we of course give meals to mothers and the children during their pregnancy, and this has been significant in helping them reduce their mortality rate. The model of Aragonda has actually been duplicated in 5 different environments. And that is something. We also had 28 yoga teachers that went out into the villages. But now through the trainers, they themselves are doing their own yoga programs. We have a large company, I'm forgetting their name, who help us in your, hygiene. We did a hygiene park for kids to learn about, staying healthy, staying clean. We also wanted to bring the joy back into the villages, because typically, they're projected as sad environments, and we need to bring that happiness back. So a lot of community work happening there. But I think most importantly, this is rural, replicable, self-sustaining model. So anyone who wants the database, McKinsey has done a study on this. We can share the McKinsey data. Please take that and use it and spread it wherever you would like to. Because we'll happily share that data as well. So, and finally, about 10% of all our scrub suits in Apollo Hospital are stitched by the women in this village cluster. So the women are making some money, and that money goes into food or education for their children. And some of them are now saving money to put a pakka roof on their homes. So, as you all know, money in women's hands is always well spent. So that's broadly Aragunda. So thank you all very much for this opportunity to share some thoughts. All the best and namaste. You speak, I can hear you, and I'll repeat your question. Hello. Yeah.
I just from my very limited understanding of this entire thing. I just wanted to pose one question to you: is that since you were talking about how much self-care is so important now and how these are so prevalent, and how much digital health, as in digitization, can help grow more of this into a positive outcome. Ma'am, so even till now, a lot of part of India has not yet been penetrated properly with digitization. And even if it has reached there, a lot of huge part is not quite accepting, like not quite receptive to the entire concept of. So, ma'am, I understand a lot of thing is being done about this. So, ma'am, according to you, what can be done different or more in order to make this a real building block towards a moonshot of equating healthcare?
So I think it's a combination of things. Number one is language. So we have this automatic assumption that everything has to be English. I think changing that. So 24/7, our platform where we have about 14 million people, we're launching 4 languages shortly. It's very important. The second thing is that the healthcare worker, you need not, if you are too young to remember, but there are days when today you do a call to anywhere in the world and don't think twice about it. But they were STD booths where people used to share a telephone and they would sit in that one booth and share the phone. So why not put the telemedicine? And we actually have done it. I didn't share that slide, but 65,000 common health community centers have telemedicine capability. So it doesn't need to, they don't need to have a phone, they don't need to read the language. If someone in that village has access and the sense of community is taking responsibility to give that dissemination of information, and that's why I hyper focused on the ASHA work. They can be very transformational in primary and preventive care for the community. So, and again, don't sometimes get bogged down by where we are today. Look at the direction we're going and the pace of change which is happening. So in a decade from now, where can we be if we do this right?
At the top level is because of others' vision and your execution. Great presentation. Also, my simple question, madam, what are your views on Prime Minister's focus on generic medicine, Jan Aushadhi Abhiyan, and also on the concept of family doctor?
So, they are both very large questions. They've modified it, but I think it is a tool towards the aspect of access. But access and its impact on research and money going in there are at crossroads. So it is not an easy answer. It has to be a calibrated answer. So life saving, like you did in vaccine, that was a life saving crisis. You didn't worry too much about what you were copying and where you were doing, but you gave it to the world. Similarly, if we do it not as a broad case policy, but in specific intervention, then I think it's acceptable. If you use generic to copy everything, then India will never have the right name in the global pharma world, nor will we spend enough money on genuine research, which is the next frontier towards new cures. We call them cocktails.
Very difficult.
Absolutely. You're absolutely right. But beyond that, I think the bigger problem in pharmaceutical, which India should handle, is our lack of API. If we don't do genuine API manufacture, we could be vulnerable. So that I think would be the area I would focus on.
Thank you very much, ma'am, for a very wonderful lecture. Now I request our chairman to present Dr. Sangita Reddy with the ASCII memento as a token of our thanks.
Thank you, ma'am.
Mr. Nagabhushanam will propose the formal vote of thanks.
Pleasure, privilege to propose vote of thanks on this occasion. Whenever I attend this annual memorial lecture, there are two persons always come to my mind with emotional attachment. One is Dr. V. Chandramowli Garu, who gave immense support and strength and guidance at the time of this formation of our essential medical services, which is a no-profit organization. And I salute him from my heart of hearts. Secondly, Dr. A.P. Rangarao is actually my classmate for the last 40 to 50 years, and we were all together spent quite a bit time in establishing this EMS with the help of Dr. Chandramowli Garu. And Rangarao, A.P. Rangarao is the actually founder. And he has taken lot of pains. I know how much pains he has taken, which we couldn't, ordinary doctors, we couldn't take it and spend that much of time. So he used to think always, day and night, to establish how best we can take the health care to the poorest of the poor. That was the main aim of that. So that is the reason why we started actually in the village telemedicine, and we are still running for the last 20 to 30 years. So Dr. Rangarao is a founder and struggled hard to form this non-profit organization, that is EMS. On his last wish, Dr. Rangarao's wish was, because we established that one, Dr. Chandramowli Garu helped this, and we wanted a memorial lecture, and we requested ASCII to establish a memorial lecture on his name, actually. So, and Dr. Chandramowli Garu. And now I thank the senior most Dr. Padmanabha Garu, Chairman of the Court of the Governors and Administrative Staff College of India, for personally gracing and presiding over this function. And sir, your presence definitely added a grace and value for this function. And I thank very much on behalf of our staff of EMS. And secondly, I profusely, wholeheartedly thank Dr. Sangita Reddy, so Joint Director of Apollo Hospital, for delivering this really we were very much, I haven't come across that a good lecture with all the things. Definitely, it is a very interesting and illuminating guest lecture. And I also thank O.P. Singaru and Akti Garu for this making such arrangements. And once and for all, I thank every invitee or guests and students for attending this function and make it a great success. Thank you very much.
I will. I'll just read and